Autoimmunity describes the loss of self-tolerance by the lymphocytes. Basically, the T cells and B cells now attack the body's own tissues. For some reason, and there are a few theories as to why, women are more afflicted with autoimmune disorders than men. Some of the autoimmune disorders I will discuss are listed here. Graves' disease leads to hyperthyroidism. Hashimoto's thyroiditis is another autoimmune disorder of the thyroid, but this time antibodies will destroy the thyroid gland, and this leads to hypothyroidism. Another autoimmune disorder I will cover is Myasthenia Gravis, and this is a disease where antibodies destroy the nicotinic acetylcholine receptor on the surface of skeletal muscle. As a consequence, the patient has progressive muscle weakness due to the loss of nervous stimulation of the muscle cells. You have also heard of type 1 diabetes, also called insulin-dependent diabetes mellitus. In this case, antibodies destroy the beta cells of the islets of Langerhans found in the pancreas. This leads to the inability for insulin-dependent cells of the body to import glucose from the plasma. Multiple sclerosis occurs when antibodies attack the myelin sheath around neurons, and this leads to a decline in the speed of the action potential. I will also talk about systemic lupus erythematosus and rheumatoid arthritis on the next few slides, and as well as Crohn's disease and multiple sclerosis in more detail. So let's talk about rheumatoid arthritis. It is a collagen disease and often ends up deforming the patient, and it's when the antibodies chronically attack and destroy the collagen within the joints of the patient. The patient ends up with hands and feet severely flexed and curled inward, and extension of the joints is extremely difficult, if not impossible. Characteristic of rheumatoid arthritis is the development of an extensive network of new blood vessels in the synovial membrane that contributes to the advancement of the rheumatoid synovitis. This destructive vascular granulation tissue, which is called pannus, extends from the synovium to involve the bare area. I'll remind you, the bare area is a region of unprotected bone at the junction between cartilage and subchondral bone. Pannus is a feature of rheumatoid arthritis that differentiates it from other forms of inflammatory arthritis. So I'll remind you that rheumatoid arthritis, and on the next slide, systemic lupus erythematosus, they are examples of type 3 hypersensitivity, which means an immune complex is being formed between the RF antigen or rheumatoid factor. It's going to react with an IgG, and this is going to lead to complement fixation. Again, this can target organs and joints, and it leads to a global inflammatory response. And this is going to lead to angiogenesis in the synovial membrane and that pannus invasion. And this means destruction of articular cartilage and underlying bone. And this is part of the reason why the person's hands and feet get turned inward. And all of this is because of the helper T cells releasing cytokines and leading to more inflammatory response. Systemic lupus erythematosus is another type 3 hypersensitivity. It's a chronic inflammatory disease. Again, we're going to have B cells generating IgGs, and this is going to react with antigens, self-antigens, and lead to the tissue fixation, means that the antigen antibody gets stuck in the tissue, and this is going to provoke complement fixation and damage the underlying tissues. The antibodies produced are actually against nuclear and cytoplasmic components. And systemic lupus erythematosus is called the great imitator because it affects any organ system. So it's a chronic inflammatory disease that affects many systems, and the initial manifestation is a red rash around the nose and mouth, and it looks almost butterfly-like, like a butterfly mask on the patient's face. One of my favorite autoimmune disorders to discuss is Graves' disease. Graves' disease occurs because it's a type 2 hypersensitivity. we're going to see, we're going to see antibodies generated against the thyroid-stimulating hormone receptor, which is found on the thyroid follicular cells. These are the cells that are responsible for making thyroid hormone. So these antibodies are called thyroid-stimulating immunoglobulins, or TSI. And this is going to disrupt the HPT axis. Normally, the hypothalamus releases thyrotropin-releasing hormone, or TRH. This will have a positive effect on the thyrotropes in the anterior pituitary. They will release thyroid-stimulating hormone, which will have a positive effect on the thyroid gland, the follicular cells specifically, and they will release thyroid hormone, which consists of T3 and T4. Unfortunately, in a person with Graves' disease, they make TSIs. They behave as if they are TSH, and that they will directly bind to the thyroid-stimulating hormone receptor on the thyroid cells and stimulate them to release TH. The copious amounts of TH being released will feed back and negatively inhibit the upstream hormones. So TRH levels will drop, as well as TSH levels. A person who presents with hyperthyroidism but has low TRH and low TSH, we are going to suspect that they have Graves' disease. And we actually can do ELISAs and radioimmunoabsorbent assays to detect the levels of TSIs in their blood. Hashimoto's is another type 2 hypersensitivity. In this case, antibodies are going to lead to the destruction of the thyroid cells, and this will lead to hypothyroidism. With hypothyroidism, the person is going to have increased weight gain because thyroid hormone helps increase metabolic rate. So this person will have a decreased basal metabolic rate and increased weight. The person could have a goiter. By the way, a goiter is not something that we use clinically to diagnose hyper or hypothyroidism, as a person can present with a goiter in either case. A goiter simply means an enlarged thyroid gland. We can see patients with goiter in hyperthyroidism from Graves' disease when the TSI is overstimulating the follicular cells. This leads to their hypertrophy, hence the goiter. But we also can see goiter in a person with hypothyroidism. And the reason is that as the thyroid is being destroyed, the healthy cells that remain are responding to the increased TSH production from the anterior pituitary. You see, as thyroid hormone levels go down, then the upstream hormones would increase in their secretion. TRH levels would go up, and so would TSH. And so the remaining thyroid cells would hypertrophy in size. The person would also have mixed edema, which is edema of the non-pitting type. This is not a problem with the Starling forces. This has nothing to do with colloid osmotic pressure, etc. Basically what happens is there's an increase in glycoproteins accumulating in the interstitial space. And this is going to lead to a special type of edema. So Hashimoto's disease and idiopathic hypothyroidism will have similar symptoms. Idiopathic hypothyroidism simply means that some cellular problem is occurring in the follicular cells, whether it be the peroxidase or the organification of the thyroid hormone. Something's going wrong and they're not making competent thyroid hormone. Another type of autoimmune disorder is thrombocytopenia. Thrombocytopenia is again another type 2 hypersensitivity, and with thrombocytopenia, what happens is we can get thrombocytopenia from a drug reaction, such as a reaction to penicillin or a sulfa drug. These drugs can bind to blood cells or platelets, forming a complex that induces antibody formation. Antibodies then target platelets for destruction by the complement-mediated lysis. The destruction of platelets, or thrombocytopenia, interferes with the body's ability to clot and leads to the formation of purple hemorrhages or purpura under the skin. So again, a drug, the hapten, will bind to the platelet, and this is going to form a hapten platelet complex. The complex will induce formation of antibodies against the hapten, and the anti-hapten antibody is going to attach to that antigen hapten complex, and the action of the antibodies and complement system will cause platelet destruction. So it can be an autoimmune disorder. It can be seen after a viral infection, or it can result because of IgAs or IgGs targeting the platelets due to a drug reaction. This may spontaneously recover if the drug is stopped being used, or once the viral infection is cleared, but sometimes not. And if it's not self-resolved, then we can do a splenectomy on the person. All right, what about multiple sclerosis? Well, just to give you some brief background on neuron physiology, here we have two neurons. They are the same length, relatively the same length on the screen. One is non-myelinated and one is myelinated. With a non-myelinated neuron, an action potential would be conducted at a much slower rate. This is taking forever for the electrical signal to get all the way to the end. Feel free to ooh and ah, that takes a long time to do. Okay, with the myelinated neuron, we see that the action potential can conduct itself through saltatory conductance. That means to jump. It jumps from node to node, node to renvier, and it goes the same distance but with greater pace. With multiple sclerosis, we're going to see that this is again a type 2 autoimmune disorder where you're going to have antibodies making a complex with antigen and leading to a complement response, whereupon the myelin sheath is being attacked and destroyed. When this happens, there's going to be reduced conductance rate, and again, there seems to be a greater ratio of males to females afflicted with this, and people of European descent have the highest incidence. To date, from what I've read, we have not found the antigenic substance in myelin that leads to this immune response. Patients have a difficult time describing their symptoms. They present with paresthesias. That means abnormal sensations, tingling in their hands. They might feel like their legs are on fire, something like that. And then all of a sudden, these paresthesias self-resolved, and it can be followed by weakness in the leg or visual disturbances. And usually the patients don't complain about these factors because they just think, well, maybe I was sick with a virus. I just wasn't right. But eventually, the paresthesias come so frequently with very little time in between them where they've resolved, and the neurologic deficits become too frequent, and then they go seek the help from their physician, and then the diagnostic dilemma begins. Myasthenia gravis is another type 2 hypersensitivity. In this case, we're going to have antibodies, IgGs, attack nicotinic acetylcholine receptors, and this will cause the receptors to be internalized and degraded in skeletal muscle. A person who presents with myasthenia gravis will have flaccid paralysis or decreased motor tone. And a way to diagnose this is to ask them to look upward, and then they will have ptosis of their eyelids. Their levator labii superioris won't be able to keep their eye open. So what happens is we can give them neostigmine or pyridostigmine, and these are drugs that will temporarily inhibit acetylcholinesterase. By temporarily inhibiting acetylcholinesterase, the acetylcholine remains in the synaptic cleft longer, and this can stimulate any remaining nicotinic acetylcholine receptors. Now, a person with myasthenia gravis can have a cholinergic crisis or a myasthenic crisis, and they can present in your emergency room with muscle weakness, either because they have flaccid paralysis or, in the case of a cholinergic crisis, maybe they overdosed on their neostigmine or pyridostigmine. And either way, you can't hold your muscle contraction indefinitely. So how are you going to know if they've overdosed on their drug or if they haven't taken their drug? We give them edrophonium. This is an acetylcholinesterase inhibitor. It's very short-lived. So if they haven't taken their neostigmine and you give them the edrophonium, they will improve. And that will help you diagnose that they're in a myasthenic crisis, meaning they need to take their medicine. But if their symptoms don't improve, then, or signs and symptoms, then they are in a cholinergic crisis, which means they've overdosed. And then you need to give them something like atropine or some sort of anti-acetylcholine drug like Benadryl. Lastly, I'm going to finish on Crohn's disease. This is inflammatory bowel disease. This does have a familial occurrence. That means that if your mom had it or dad have it, then there's a greater chance that you'll have it. We haven't identified a true genetic component, but there is a familial occurrence. Crohn's disease typically affects the small intestine, the distal portion of the small intestine, and proximal colon. It leads to granula-like lesions or granulomatous lesions that give this kind of cobblestone appearance. It is, again, the inflammatory cells that are causing this non-specific tissue damage. The patients will present with diarrhea and weight loss. That concludes the end of our disorders of